All right, everybody. Good morning. Welcome to Grand Rounds. Grand Rounds this morning is going to be followed up by Unknown Conference. So I'd like to introduce Dr. Jason Abel. Dr. Abel is a professor here in our department on the clinical health science tract. He's also the head of section of oncology and holds the Robert and Dolores Chenet's Chair of Urologic Research. At the national level, he's been recognized and sits on committees within the Society for Academic Urology and on the board of directors of the Society of Urologic Oncology. He did his medical school work at University of Texas in Houston, followed by his residency at Utah and a fellowship at the MD Anderson Cancer Center. And he's been recognized by the AUA for his accomplishments as a young investigator by holding one of the Gold Cystoscope Awards. So without further ado, turn the podium over to Dr. Abel.
Thank you, Dr. Williams, for the kind introduction, as always. So this morning, we're going to talk about testicular cancer. Can you guys hear me okay in the back of the room? Jeremy? Yeah. And we'll focus on the surgical treatment of testis cancer. This is not working, so use this. Maybe? Okay. So you just look at the epidemiology of testicular cancer in the United States, only about 9,000 cases in the United States. And when you look at the estimated deaths, again, 0.1% of the patients. The relative survival is very good. You can compare this to some of the other cancers that we treat. So prostate cancer, 8.6 cases for every patient that dies, and then pancreas is almost 1 to 1, 1.2 to 1. So again, it's something that we've made a lot of strides in. 24 patients for every one patient that dies we treat. It is the most common cancer of men 18 to 39 years old. So I wanted to look a little bit deeper into this, and we just got this information back from the Carbone epidemiologists. So in Wisconsin, this is the catchment area for 2016 to 2020, which was the last years that they had complete. And so we coned on down to the urologic cancers here. So kidney, testis, prostate, and bladder. And if you look, the kidney, testis, bladder, prostate, obesity-related cancers, tobacco-related cancers, they're all higher in the Wisconsin cohort than they are in the general United States cohort. And what this means is if you look at the yearly cancer incidence and just look at bladder, kidney, prostate, and testis, 23% of all cancers in Wisconsin are treated by urologists, diagnosed and treated by urologists. So again, this was one of the things that got me into cancer care, the fact that you could be a urologist and treat all these different patients. If you look at this though, testis, again, is a very small minority, only about 3% of the cancer cases that urologists treat. And so you really have to study hard on this stuff and remember it from patient to patient. When we talk about testis cancer, we always talk about being the model of treatment success in solid tumors. In the 1970s, more than 90% with metastatic testicular cancer died. And currently, more than 90% of patients who have metastatic testis cancer, even widespread testis cancer. I mean, I think Lance Armstrong, his enduring legacy was he had tumors all throughout his brain and lungs. And still, did very well. This is because of chemotherapy and advanced disease, largely. You can compare this to prostate cancer and then contrast this with renal cell cancer. Testicular cancer is a model of a cancer that can be treated with chemotherapy. Again, this is just more data. If you look at the bottom lines here are the 1960s, and the top lines are 1990s through 2000s. And you can see both for seminomas and non-seminomas, the relative survival is way better across decades. So you just don't have, and this looks at all stages. So again, much better. Why is it different? Quite simply, it's because its growth rates are faster than any other solid cancer. It's aggressive, it's treatable. Some seminomas have growth rates or doubling times of less than 2 weeks, right? So that's just like a lymphoma or a leukemia. So what does this translate for us? Minimal delay to orchiectomy, right? And chemotherapy radiation is effective because it preferentially destroys dividing tumors. So that's why chemotherapy works so well, because they're dividing so quickly. It can differentiate between the rest of the cells in your body, whereas other things that grow slowly, prostate cancer, for example, what didn't typically have a ton of success with chemotherapy, some of that's changed recently. Also, generally, testis cancer spreads reliably. It goes through the retroperitoneum first. The exception that you have to know for your test is choriocarcinoma, but testis cancer behaves the way we think cancers should behave. And so in 2024, what is the role of surgery in testis cancer? I think radical orchiectomy is not something that's debatable or we'll even talk about much, but primary RPLND versus observation or chemo, and then post-chemo RPLND, and we won't talk too much about desperation surgery since it is so rare. I like this quote, and I feel like this is like all of residency. You have to learn everything, and then you can learn why you were wrong. So radical inguinal orchiectomy, there's no debate. It's way better than biopsies or markers. Occasionally, we defer it, maybe once or twice a year. We have somebody that has life-threatening bulky lymphadenopathy so that we can just start chemotherapy. And again, for treatment purposes, we divide them into seminoma versus non-seminoma. Can't get away from this slide. I just love this slide. And it's like 12 years old. But this is what Williams was riding around on when I first met him, surprisingly quickly. Sperm bank prior to orchiectomy, get it into your heads. Just it's a difficult time. You catch young patients off guard at a time when they're not thinking about their future fertility. So if there's any question in their mind, unless they've had a bilateral vasectomy and have 5 kids or something along those lines, really try to sperm bank prior to orchiectomy. You can always go backwards. So post-orchiectomy, observation, RPLND, chemotherapy, radiation, all different options. And really, we need to know what the chances are that you're going to recur. And that's always what the patients want to talk about when they're in clinic. This is a Pete Rose quote. If I'd be willing to bet you, if I were a betting man, that I'd never bet on baseball. It's a great quote because a lot of the things we do and a lot of things patients think about are based on their relative risk and also their risk aversion. As humans, we're all programmed to be risk averse. We all would rather avoid a negative than gain a positive. It's just something that's been programmed into us since evolution. It was much better to avoid a lion than it was to get a piece of fruit, right? So I looked into this a couple of years ago. This comes up a lot. Just in the last couple of weeks, the lotteries were both over $1 billion. Your chance of winning the lottery is somewhere about 1 in 300 billion dollars, either Powerball or Mega Millions. Yet, on average, an American spends between $2,000 and $1,000 on the lottery every year, right? $108 billion in 2022. That's more than movie tickets, sports tickets, and video games combined. Like, that is an amazing number. It pulls in a lot of people. So when I saw these numbers, I was thinking, okay, maybe these are people that maybe they're not highly educated. Maybe they're younger people. They're just, that's the time they have. Or maybe it's people that aren't making a lot of money. So turns out there's data on that. This is a Gallup poll from 2016. This was the median income and then some income thresholds here. You're more likely to play the lottery if you had the median income at that time, or if you had a higher income than if you had less than the poverty level income, which, again, really interesting. If you look at level of education, so people with college degrees are more likely to play the lottery versus people with high school degrees. Again, not exactly conforming to my bias. And then if you look at age groups, I mean, this is definitely an okay boomer slide. It's people in their 60s are playing the lottery twice as much as people who are younger, right? So I put this up for two or three reasons. One, it's a bias. We all have them. Everyone seeks to confirm their biases. You need to look them up and you kind of need to understand this, right? Two, What is the lottery selling? It's selling hope. It's selling hope that you can make such a massive change. People are really looking for that. And when they're looking for that from you, we need to really try to be as articulate, but also understanding of how they use this information. So I have 4 patients here. I just want you to think about the different nuances on how we counsel these different patients, even though they would all get similar information. So a 28-year-old with 100% embryonal cancer with LVI. He travels with the circus. Markers are normal and CT nodes. By the way, these are all my patients and they're real. I was surprised that there was a circus as well. Okay, again, treatment options are primary RPLND, chemo, radiation observation. Patient 2, no comorbidities. He had radical orchiectomy. He only had 50% seminoma, 30% teratoma, 20% yolk sac, med student. Markers are normal, CT, no nodes. Again, same options. Third patient, 28-year-old, he had a radical orchiectomy. He had 100% embryonal. Markers normal. He has a 6-centimeter total nodal involvement, Fred's retroperitoneum, and a tiny nodule in his CT chest. This is probably the easiest patient to treat because he has less options. He would probably be chemotherapy up front, but there are people who would do a primary RPLND radiation or observation on this patient as well. And so the fourth patient, 30-year-old, status post radical orchiectomy, 100% seminoma, markers normal, CT normal. This is a pharmacist at the hospital. Again, you would think you would know where this patient would end up. Let's see, Emily, how would you counsel this patient and what would you do for this patient? Yeah, good. Those are all good things. What makes you think one way or another for this patient? Mm-hmm. Lower risk. So I'll just give you, he's about 20 something, to low 20% risk of recurrence. Right? What, I mean, the fact that he's a pharmacist at the hospital also thinks he's going to be around healthcare. He's not going to just go and not be found. But discussing with him the nuances between chemotherapy and observation are going to be huge because sometimes people have reasons one way or another. So when we look at how to predict occult metastases in stage 1 non-seminoma, this is a good systematic review. Looked at predictive systems. So really vascular invasion, lymphovascular invasion, and embryonal predominance, so embryonal 50% or more. In this group of all clinical stage 1, about a third of them had occult metastases, right? So if you take out the patients that have LVI or embryonal cancer, you decrease the risk of the people that have occult metastases. So really when we think about observation, patients with low risk tumors, but what is low risk? Low risk to you might look different than low risk to somebody else. In non-seminoma, it's patients without LVI or embryonal, 10 to 20% have occult metastasis. You also have to throw in teratoma because teratoma ends up making your decisions a lot too because it's chemo-refractory and grows really slowly, so it's not going to recur within the first 2 years. You do need a lot of imaging and markers. Patients need to be reliable. You look at some studies that only 20–30% of testis cancer patients end up being compliant with their, unless you look in Scandinavia where people are much more compliant, it turns out. This is a surveillance, proposed surveillance follow-up for non-seminoma. Every 1 to 2 months, every 2 to 3 months, depending on where. We have de-intensified these a lot, but you're still getting lots and lots of imaging, lots of tests in the first 2 years. And there's a lot of different surveillance regimens being proposed. When we think about chemotherapy, so Patients with bulky lymphadenopathy, that third patient, elevated markers, disease outside the retroperitoneum, that's a great option for that patient because it treats the entire patient. It's definitely an option in some stage 1 patients with high risk of occult metastasis, but you really have to understand the risk of primary chemotherapy or surgery. And if you make a case for primary RP&D, I know I like to make this case because I do think that there really is a role for this. So you can look at history, the best outcomes for higher risk stage 1 and 2A. Where you get to 2B, so patients with 2 to 5 centimeters of a tumor, that gets a little bit iffy. And the downside is it doesn't treat outside of the surgical field. Better staging, when you have a patient that's stage 1, clinically you've understaged them 30% of the time. Stage 2, 30% of the times you've overstaged them. Chemotherapy is toxic, so you can take your morbidity now or later, but you can really limit surveillance, so do less abdominal imaging. So if you look at history, I can't get away from these slides. I made them years ago, but I like them. So this is 1902. This is before X-rays, before endotracheal tubes, before antibiotics. Sulfas and penicillins came along in the 1930s and 1940s. And this is read before the American Surgical Association. Great quote. There'll probably be little dissent from that operations for malignancy should usually include the removal of adjacent lymph nodes. To permit the lymphatic glands to remain until affected by secondary involvement is a grave order of judgment, right? This is arguing for primary RP&D 122 years ago. It then talks about which nodes to take, and again, very close to what we do now. Fatal results may occasionally follow such surgical methods, but the risk must be taken to struggle with a relentless enemy. That's a little bit more dark. Okay, so this, 1914, Frank Hinman, I'm going to point out that he was a assistant resident surgeon at Johns Hopkins. This was the older Dr. Hinman. Take a look at that incision they would make, just huge. They would get out some massive retractors. Again, this is before endotracheal anesthesia. One of the quotes, radical operations should never be undertaken when they're fairly recognizable or applicable only in early cases. So again, this is arguing for only in early cases do we cure people of this. You know, we do the exact same thing 100 years later. It talks about embryonal carcinoma and teratocarcinoma. Now we move forward to 1959. In the absence of clinical metastasis, orchiectomy followed by bilateral RP&D through a transperitoneal approach. And again, so this is 127 patients they had that had clinical stage 2 non-seminous germ cell tumors, all of whom got orchiectomies and radiation. All of those patients died. They had a second group that were stage 2 that got RP&D. And it's amazing that half of those patients survived. So this is pre-chemotherapy, this is pre-anything. You have taken somebody with metastatic disease and rendered them disease-free. This is a win any way you look at it. But modern radiation chemotherapy do work well, right? So why don't we give it to everyone? So the easy risks, the easy answer is there's a risk of secondary cancers, cardiovascular disease, and diabetes. This is an early study, looked at 90 patients. About 5 years afterwards, a third of them had a Raynaud's phenomenon, 20, so 1 out of 5% of patients had hearing loss, peripheral neuropathy. I had a patient a few years ago that had to quit his job as a computer programmer because he could no longer feel the keys. These are big deals, right? And so this was a pretty limited number of patients with a limited number of follow-up. As things went along, you got more patients and better follow-up. So this is around 2000, 6% major cardiac events. These are people in their 30s having major cardiac events. So that's a 7-fold increase over just the general population. Things like hypercholesterolemia, hypertension, Raynaud's, microalbuminemia. This is the best study because this looks at 20-year outcomes in 2,700 patients. So, and if you look at the Kaplan-Meier, the line all the way to the right is surgery only. The line all the way to the left is subdiaphragmatic radiation therapy and mediastinal radiation therapy. And then as you go down, it's different radiation therapies and chemotherapy. So the more we treated people, the higher risk they were of getting a secondary malignancy. 2.5 times risk with radiation therapy. It's a little bit less with chemotherapy. It's why we rarely do radiation therapy for testicular cancer, because we know the risk is worse than it is with chemo. It only treats what's in the field. There's some in-field recurrences. I don't see any radiation oncologists in the room, but that's a lot of the reason why we don't treat with radiation anymore. And again, you see major late complications with chemo and radiation are significantly. Now, there's definitely some biases in this data, but I think it's what we have. If you look at the cardiovascular risk factors, again, a 20-year study, and then just look at normal age-matched controls all the way on the left, and then patients who got radiation chemotherapy, 4 times increased risk of being on a hypertension medication, having a diabetes diagnosis, being on a lipid medication. Interestingly, it decreases your risk of obesity beyond your normal age-matched controls. But that's also kind of a twist too, because most people on who had diabetes or hypertension on lipid medications are obese. If you look the hazard ratios for having cardiovascular endpoints, again, 5 to 6 times higher than the normal age-matched controls in this group. So chemotherapy summary, it works well to kill cancer, but it has risk of secondary malignancy, cardiovascular disease, diabetes, hearing loss, infertility, Raynaud's phenomenon, Raynaud's disease. It's still the most complete cancer treatment if you ignore the complications, because it treats cancers throughout, not just the surgical or radiation field. So what about a post-chemotherapy RP&D? With modern chemotherapy, I'm sure you guys see this on your test, 10% chance of viable tumor, 40% risk of teratoma, 50% risk of necrosis, masses greater than 1 centimeter. There's really no prognostic system, PET imaging, or any other way to determine if mass is greater than 1 centimeter harbor cancer. There's too much sampling error, so we do end up doing surgery on these patients. Never do a lumpectomy, always do a bilateral retroperitoneal node dissection, especially if patients had disease in the past. You can argue about templates, but for the most part, we recommend doing it bilaterally. Masses that are less than 1 centimeter, you can observe with some minimal risk. This is a post-chemotherapy masses less than 1 centimeter. This is out of data out of Indiana, published in JCO in 2010. 141 patients who had response to chemotherapy and were observed afterwards with a less than 1 centimeter mass. Only 9% relapse with a median follow-up of 15 years. So again, very small relapse in this 1 centimeter cutoff, and 4 of those patients died of disease. Small numbers, but young patients, and so there's high risk. So some places continue to recommend post-chemotherapy for everyone. Some places, less than 1 centimeter, they just do observation. So again, the role of RP&D. In seminoma, there are these multi-institutional trials ongoing, two of which have reported not great results. Post-chemo, very rarely in seminoma. Most of the time you get a PET scan, and that is a non-avid. It's one of the few places that we recommend PET scan with testis cancer or with other non-prostate cancers. For non-seminoma, either as a primary method of treatment or post-chemotherapy, and then desperation when nothing else is working after chemotherapy. Occasionally we do RP&D. These are the nodes, and I always put this up here because I don't know anyone that I've done these cases with. When you do the split and roll technique, you can really make a paracaval package look like a precaval package, depending on where you're going. So the things that are reported, you always have to take them with a little bit of grain of salt, because the package can move to one side or another depending on how the person's doing the dissection, depending on what they send to the pathologist, depending on what gets plucked off. So this is a beautiful anatomic process, but we don't send this en bloc to the pathologist who dissects it for us. So full bilateral post-chemo RP&D. This is a patient I also just saw in clinic. They're 12 years out, now doing well. Had this tumor just completely engulfing the aorta. It was actually, there's a patch here on the aorta. We had to remove a portion of the aorta because it was into the wall of the aorta, which is super rare. This is the tumor here on the side. Patient's doing well, has 3 kids. This is what we think of when we say bilateral RPL&D. I'm not going to run through all this stuff, but retroperitoneal access, mobilizing duodenum, incising the posterior, and getting this fully exposed view. It's a great case. How do we maintain ejaculatory function? Again, three components, the sympathetic trunks from L1 to L4, postganglionic sympathetic fibers in the hypogastric plexus. Also, so there's two ways people do this. Either they prospectively find the nerves, and we do this occasionally, or we do modified templates. So if you do a modified template, you basically stay away from the nerves on that side. This is the data from Dr. Jewett. He did bilateral full template nerve sparing. He was unsuccessful when there's Gross disease, really tried to preserve the neural structures, but was technically feasible in 20 to 30 patients. And even with patients with large nodes and antegrade ejaculation was preserved in 90% of these patients, and no retroperitoneal recurrences at 19 months. Again, this was kind of a historical article put in there. The most important nerves to preserve, L3, L4. You don't have to, we usually prospectively take 3 or 4 arcades, and then the rest of them we're less careful with. Carefully ligate the lumbar vessels, prospectively identify these with vessel loops, and then split the pre and periaortic nodes after we identify the nerves. But again, you have to think, if you have a tumor running right through it, we don't compromise oncologic principles. Templates designed to look at, to spare the nodes from the most likely regions and leave the nerves on basically half of the retroperitoneum. So multiple modified templates. I really like this study. This was done by Scott Egner when he was at Sloan Kettering as a fellow. Looked at these bilateral node dissections and then applied different templates to them. So 483 patients, lots of follow-up. 26% were stage 2, and only 3 retroperitoneal recurrences, 2 deaths. So this was the right template. This is a left template. If you look at different groups, they use different templates, which are modified only slightly. So this was one of the earlier ones, 75 patients. They cut their blood loss, and it really kind of moved things along. This was Steve Beck in 2007. So are the templates missing anything? This is the German testicular intergroup, randomized 168 modified versus 67 bilateral. Follow-up of 30 months. Retroperitoneal relapse in the template group was 2.4% versus 1.5%. Overall relapse 17 versus 15. Complications really no different. Antegrade ejaculation. This is still a little bit higher than we would see in other historical groups. So again, going back to Dr. Egner's study, 500 patients, full infrahilar dissection. And when they looked at that, so the top chart shows testicular TTSD, so it's the German group, Indiana template, the MSK modified template, and then the Johns Hopkins group modified template, right? And they did bilateral, and they post hoc applied these templates and say, hey, are we missing anything? But this is primary disease. If you look at table 3, these are the extra template without intra template. So this is the actual times you would make a mistake. And if you look at like the Indiana, the MSKCC things here, you would never miss extra template disease if you had intra template disease. So the learning point here is if you have intra template disease, then you do a bilateral node dissection. Templates are actually really good for primary RPL&Ds, in my opinion, and I have been changed that way since becoming faculty, because I was definitely trained to do always bilateral dissections. So again, what about the post-chemotherapy setting? So Brett Carver looked at this in the post-chemotherapy setting. They had 532 patients post-chemo who underwent RPL&D and did the exact same thing. Now in the post-chemotherapy, this is extra template without primary in template. Now it's really more the story that's actionable as far as in patients who've had chemotherapy, templates can miss things. Now there's some other data I'm not going to present. in follow-up from Indiana where they had, again, more thoughtful use of some templates. But it's tough to know, and it's really tough to retrospectively go back and do this because my template might be different than yours, just depending if I cut like right in the middle of something versus, more to the side. So conclusions about the extent of surgery. For primary RPLD, template or bilateral nerve sparing seem to be very good options. Post-chemotherapy, I still think we should do bilateral. This is the first patient I did a robotic RPLD on. I think we've done about 30 now. You can see, anyone that's ever been to my clinic knows that this is not a typical patient. This patient is smaller. We've done them in larger patients now, but I think it's a good option when you're going to do a template RPLD, somebody with like 100% embryonal or teratoma. I think those are also good patients. I think you clean out the retroperitoneum. Every patient to this day, I've told them that we'll probably convert to an open, but we have not done it yet. So knock on wood, but I think this is a reasonable option. There's some data on laparoscopic and robotic. This is from December 2023. This is just a systematic review and meta-analysis. If you look at the numbers, there's one study here that's just a population-based study with 269. The rest of the numbers are, the highest number is 44 patients receiving robotic RPLD. Again, not very many numbers to make a compelling case. This review said less EBL, shorter length of stay, fewer high-grade complications, faster recovery, no difference in recurrence. It's probably not the same patients. I can tell you for sure I selected patients that are not super high-risk disease, not patients with lots of disease in the retroperitoneum. But we've expanded as things go along. And I think it's a good option because the patients do leave the first day and they recover faster. Love this. It's great for anyone that does surgery because you feel like you're doing this, a lot, going from failure to failure of, just being happy. And depending on how you interpret this can go, this quote can really go several different ways. Complications, this is just from Cleveland Clinic, higher rates in post-chemotherapy patients. Again, we know that. Wrap up here in just a second, but open RPLD, higher rates in post-chemotherapy patients. The mean operative time is long, right? So you're looking at 5 hours for the median operative time at a center of excellence, median blood loss, around 1,000 you're working. But if you look out here, 14 liters is definitely, on the range here. So it's something that this can be a very complicated comorbid case. Early complication rates, only 3 to 6% were major complications. There's also late complications that sometimes you don't see early on. These were the list of complications. Again, a lot of them early on, ileus. But when you look at grade 3, things like hyelosocites requiring drainage or small bowel obstruction, and then pulmonary complications, especially in patients who have received chemotherapy. Late complications, mostly hernias, but also small bowel obstructions and lower extremity edema. So if I was going to make some conclusions, radical orchiectomy, unless metastatic disease burden is large. Primary RPLD is a good choice. We should offer our patients with high risk embryonal or LVI or teratoma. Patients wish to avoid chemotherapy complications, which are real. We don't know as much for the smaller doses of, like 1 cycle of BEP or 2 cycles of carboplatin. We don't know what those risks are, but we think they're still increased versus not getting it at all. Evidence for templates is better for primary RPLD versus for patients with low risk. Chemotherapy and redo RPLD do not compensate for an inadequate initial RPLD. So really no lumpectomies, going in and doing a full node dissection. Conclusions regarding the therapeutic efficacy cannot be made if postoperative chemotherapy is given. So if we go in there and do robotic RPLD and then we do adjuvant therapy on everybody, I don't know who would have just done fine. And so none of my patients have gotten adjuvant afterwards. It's one of those things that you'll never know in these small series. Complications are significant, but at a lower rate compared to post-chemotherapy for primary RPLD. I put this one slide in here because I think this is about how much you'll hear about this. You go to meetings. So SEMS and prime tests were two single-arm clinical trials where doing primary RPLND for stage 2A or stage 2B seminoma. So people that had somewhere between 2 and 5 centimeters of tumor. They enrolled 55 and 33 patients respectively. And then the 2-year recurrence-free survival was 89% and 69% respectively. It's hard. Some people are taking this as evidence that we should be doing RPLND for seminoma. I think a lot of people are still looking at it and saying, well, if I can avoid anything for most of these patients, maybe that's the way to go. Since they're 2A and 2B, maybe you're not going to avoid. So maybe it really is a chemotherapy for some of these patients. So do you avoid, 3 cycles of chemotherapy? Maybe for these patients. And so maybe it has something. I think it just needs more data. Recurrence-free survival of 89% is hard to argue with in the prime test. 30% of the recurrences were in-field recurrences. So you might argue that that's not adequate surgery because it's in-field recurrences should happen exceptionally infrequently. I think now they're collecting more data for some of the stuff, and there's some more ongoing trials. This might be something that we do in the future, but right now it's hard to argue, especially in tumor boards, because they can argue, well, I can get you 100% or 99% recurrence-free survival with chemotherapy, and so it just looks inadequate unless you really factor in the chemotherapy complications, which again don't come for 20 years for a lot of patients. So they won't know that all these forward-thinking urologists were right for 20 years. Is another way of interpreting this. So who to operate on? Radical orchiectomy for everyone. Primary RPLND, good choice for informed higher risk patients. Post-chemo greater than 1 centimeter. Everyone if accepting risk at some places. How to operate, templates make more sense in primary disease, and post-chemotherapy if it's greater than 1 centimeter residual disease. And that's all I got.
Nice. Great talk, Jason. Question about the robotic approach to RPLND. Who in your mind do you think is a ideal candidate for a robotic approach?
Yeah, so we've picked out people that are stage 1 or early stage 2, like a small node. People that we think high risk, but we can't see it. And so the staging, it really is a diagnostic and staging procedure as well as therapeutic. We have had a few people, maybe 20% have had viable germ cell tumors, none of whom got adjuvant therapy and none of whom recurred. But again, I think you're getting things when it's very, very, very small. I think when you're waiting till you have a 5 centimeter tumor, you're just talking about like the probability of tumor being outside of the template being much higher. So I think if you choose the right people, I think it works well. Also, patients we've done some patients with Leydig cell tumors or other tumors that or teratoma. I think those are good options.
And then follow up. I know this was mostly about surgery, but we do a lot of active surveillance for patients with clinical stage 1 testis cancer. I was just looking at this morning. The guidelines beyond 5 years, sort of at discretion for continuing follow-up. In your practice, how long are you following these patients, or is it just sort of a discussion you have on a one-on-one basis?
Yeah, I think we need to follow them longer, especially patients who had teratoma, because teratoma can remain indolent and then come back, between years 5 and 10. Also, Leydig cell tumors, when they're malignant, can come back between year 5 and 10. They grow very slowly. Generally, what we have done and kind of what we agreed on as a group several years ago was just yearly for years 5 to 10, and then every other year, after that. They're definitely at an increased risk. It's hard, but it's hard to get, these young, healthy guys who think they're cured 2-3 years out to come back even in the short term.
Great talk. I just have a question about your thoughts on some of the like microRNA tests as like a biomarker for looking for disease recurrence. What do you think? Or is that something that's going to become kind of routine, or what are your thoughts?
Yeah, I think the microRNA has created a lot of buzz. I know it's more slowly adopted. I think it would be great if we had better markers. I mean, the fact of the matter is you have pretty good markers for non-seminal germ cell tumor. Anything when it's really, really small, it's hard to find a signal. And especially when you have such good outcomes in some patients, and they have fast-growing tumors. So I don't think it would be as useful, even if it worked perfectly, I don't think it'd be as useful as something like kidney cancer or prostate cancer when transitional cell cancer, where the minimal residual disease is there, you just can't see it. Because I feel like in testis cancer, a lot of times it becomes apparent. It's not something that like a year later, you're like, oh, that was nothing, and now it's, just growing.
Great, great talk. I really enjoyed it. I guess my question is, how do you counsel them? Most of the data on long-term problems from chemotherapy is in people who got, full 3 of BEP or 4 of EP. How do you counsel them if they're considering it in the adjuvant setting for, high-risk stage 1 or something like that, or the seminoma case that Emily had? I mean, I don't think in that slide you had the risk factors. I mean, there are some risk factors, although they're much weaker, and none of them put you over 50% like you have for non-seminoma. But
yeah, I think that's a great question, and we've talked because there's just not mature data. So in patients that have moderate risk disease, they get either four cycles of BEP or, 4 cycles of EP or 3 cycles of BEP currently. So they de-escalated that to just a couple cycles of BEP for non-seminoma. For seminoma, you can either get 1 or 2 cycles of carboplatin single agent. It decreases your risk from 20-something% to like 2.5% or 1.5% if you get 2 cycles. We don't know because we don't have any long-term data on people who've gotten carboplatin 20 years out. I still think there's some risk. That risk might make sense to some people. The way I've heard people say that is if you're not observing, you're over-treating 80-something%, right? Or 80%, right? We'll just make it, if you're giving everybody chemotherapy, 80 out of those 100 people didn't need chemotherapy. So you could wait, and it really depends on, how you approach medicine as a population. If one person comes in, I've had some patients that were surgeons and, were really scared of the neurotoxicity. So they did do the carboplatin because they wanted to avoid the BEP. And I think that's also a reasonable thing. The risks are so individualized, and I think you can make those cases to do on somebody. I think giving it to everybody, it's much harder to make that because I think the do no harm thought is really what we should think in all of medicine, and not giving chemotherapy unless you absolutely need it is probably a smart thing.
Yeah, thank you, Jason. That was a great review, and it's so important for the residents to have a good retroperitoneal team, and because there's so much great surgery back there for your training. I was thinking a little bit about my training. I had when I was at University of Chicago, I was trained with a guy who had worked with Jerry Ritchie, and he would do a thoracoabdominal incision for everything retroperitoneal, which is an incredibly morbid procedure. I mean, chest tube afterwards. These people are in horrible pain for days after the operation. So it really sort of soured me a little bit. And then we had John Donahue, and Jason showed a couple of those slides, who was from Indiana. I still remember when I was a resident, I picked him up in my Chevy Nova, which had a hole in the muffler, and of course, typical resident car where you had half-eaten sandwiches in the passenger side, and so I picked him up. I threw everything in the back, of course, and picked him up, and I think he grimaced a little bit, but he got in the car at any rate. But he showed us essentially a really beautiful midline incision for a retroperitoneal lymph node dissection, which I was just amazed at. So clearly that is the way to go here. So, and then we've moved on now to the laparoscopic robotic approach as well, which, again, improving the outcomes, or at least maximizing the outcomes and minimizing the morbidity of surgery. And you got to a certain question, and you mentioned the microRNAs, but what about imaging in this situation? PET has been evolving in so many. Maybe you could just speak to, and I know there's certain situations where you use imaging, but if you could just speak a little bit to that and where you see that going.
Yeah, that's a great question. I think molecular imaging is probably the future for all surgeons as far as being able to find what we're actually searching for. If you look at PSMA PETs, we find people with reasonable PSAs that have nodes outside of their prostate that we never would have seen prior to this. But it was really contingent on finding a tracer that was very avid at small concentrations of disease. When you have a larger concentration of disease, or you have 1 centimeter node, FDG PET doesn't work well. It works pretty good for seminoma, actually. But for non-seminoma, it doesn't work super great. I think it would be amazing. Again, only 9,000 patients a year, and very few ever would get a PET. It's hard to see that there would be a market to where they would develop something. And there's some things that, like OCT3/4 is something that's expressed on testis cancer, reliably. You could look for things like that, but you'd have to develop all these radionucleotides. Currently, it's not at the level where it costs, so much money that it would be difficult. But I can see in the future when you can scale up things like that quickly, maybe you could make imaging that's, bespoke for an individual patient, or that's, specific for testis cancer. That could completely change the game on what we do. Because I think right now, the fact when we do post-chemotherapy LND that, sometimes we get just completely negative nodes, that's something that we can get better at. Right. I think the teratoma is still something that we're going to continue to take out, and anything that's large, I think we're going to end up having to do still. Great. Thank you very much.
Sorry, one other quick kind of historical comment and then a quick question. So when I was training, I remember for early stage seminomas, and the radiation therapy was definitely on the list, or if not at the top of the list, to hit the retroperitoneum for low stage seminomas. And then as that 2007 paper showed, sure, the risks of the radiation outweighed the benefits. I think 50 years from now, maybe there will be a new chemo agent, and people will be looking back saying, "Can you believe back in the 2020s when they were using platinum-based chemo and all those side effects?" So as things evolve, I'm sure the benefits versus the risk ratio is just going to continue to improve. Going back to the markers, I had a thought about for your RPLNDs. Is there an ability to do some sort of like immunofluorescence and use some of the robotic platform technology to, inject something pre-op and then have some sort of fluorescent marker intra-op to help you target your RPLNDs, looking for active disease and/or for teratomas? That would potentially obviate the need to do a full template dissection to help maximize the efficacy and minimize morbidity. Is there any potential role in the future for kind of targeted therapy using the robotic technology?
And I think there's a potential, but I don't see that going anywhere quickly. Just it's so hard to develop that technology, and most of the technology now is just very non-specific, right? So it kind of targets blood flow, but it's very hard with what we currently have. But I think that's the way everybody would be going, right? You'd have to find something that was either under your whatever light you're using that would fluoresce, or would stand out. And the robot has some of that technology already built into it. But again, for testis cancer, since it's a very small proportion of the overall cancers, it doesn't have that development yet. So I think that could be the future. But again, it's hard to see because I don't think anyone's working on that just yet. Dr. Doss?
Your practice, what percent of
It's pretty rare. And honestly, it's only been maybe 3 or 4 patients I can remember, all of whom had a reason they really wanted to avoid the ototoxicity or I think of a few surgeons, a musician, and one other person that really wanted to avoid they had looked up all the chemotherapy complications with BEP and really wanted to avoid all of that. So.
Great. Thank you very much, Dr. Abel. Why don't we just take a few minutes and maybe the residents can regroup and just maybe 2-3 minutes to get going with unknown conference. Thank you, Jason.